back. This is Boomer Life on CIL 650.
Welcome back to the program. Sterling Fox with you on this Saturday morning on Boomer Life on CIL 650, talking to a couple of doctors from the Falls Creek Healthcare Center, which is downtown, by the way, on the 6th floor at 555 West 8th Avenue in Vancouver, and always online at fallscreekhealthcare.com. On the phone with us, neurosurgeon Dr. Navraj Heron. In studio with us, physiatrist Dr. Stephen Helper. And Dr. Helper sort of leaned over during the break and said, there are probably a couple of items in that opening segment, medically speaking, that could use a little clarification. We're talking about back pain on Boomer Life, and boy, I'll tell you, for boomers, Dr. Helper and Dr. Heron, back pain is pretty much a daily sort of thing. So, Dr. Helper, before I get to my next question, how about a couple of cleaning up of some loose ends from the last segment?
Sure, I'd be happy to. I think I need to start with an apology, is because you asked me a question, which was, what's a herniated disc?
Right.
And I never answered it.
You got into the hockey puck with the
right.
liquid gel in
Well,
it.
let's go back to the hockey puck just for 1 sec. So if you take that same hockey puck that we tore and caused back pain,
right,
that tearing also makes that hockey puck a little bit weak. And if you make the hockey puck weak in the back corner of the hockey puck, then that jelly from the jelly donut can start leaking out, push out or leak out.
Right.
And when that jelly leaks out, that's when we start putting pressure on the nerve, right? So when you think of sciatica, it's from that jelly pressing on the nerve. And that jelly pressing on the nerve typically causes more buttock and leg pain, so pain down into your thigh, traditionally, right?
As Dr. Heron said, some people with this sort of pain don't even have back pain. It's just all focused below the waist.
Yeah, and it's not automatic, but it's traditionally more of a neurological type pain.
Okay.
And that is the type of pain that is going to be more receptive to surgery or more receptive to all sorts of treatments.
Okay.
So back pain, it's not a black and white answer, but back pain tends to be more of a mechanical, we'll call it arthritic pain. It might be oversimplified to say that, but let's call it a mechanical arthritic pain.
Okay.
Whereas pain in the buttock and leg tends to be more of a neurological pain that can get better on its own, or can be directly treated by me or directly treated by Dr. Heron. So when we talk about access and when you intervene, there's the automatics. Our medical system in Canada is great if you have cauda equina and you have severe neurological compromise and you need it decompressed immediately, Dr. Heron or another neurosurgeon, we're going to see you in the hospital and they're going to take care of you.
Right.
Right? Same way, if it's mild and it looks like it's going to get better on its own, you don't need Dr. Heron to do anything. It's the middle guy.
Okay.
So when you have moderate pain, that's when intervening, whether it be doing an injection procedure under X-ray guidance, or whether it is to have that disc material taken away, they take that jelly out with surgery, intervening sooner rather than later actually has better outcomes. So whether you get an injection of steroids to calm things down, or whether Dr. Heron needs to clean off a little bit of that disc material off of the nerve, the studies show that the earlier you have access and get treatment, generally better people do. You don't rush in and treat people who don't need to be treated, but once you've made that decision that treatment is appropriate, people tend to do better if you don't leave them sitting there for months and months.
Okay, now to Dr. Heron, with that door now wide open, and thank you for that. Dr. Heron, when one experiences this sort of chronic pain, it's starting to happen every day. I'm trying to do my exercises, a little self-induced physiotherapy here. I'm online. I'm doing my homework. I'm doing my best, but it's just not going away, and it's the same pain every day. At what point, Dr. Heron, should I do something about this, and who do I see?
So if we just focus on the patients who have leg pain, so we're assuming that the disc is herniated and the nerve is being pinched. Typically, if they don't have any neurological dysfunction or what we call red flag features, cauda equina, foot drop, we have a tendency to at least wait 2 to 3 months to give the patients the benefit of the doubt to see if they'll follow the normal natural history, which is improvement in about 90% of these patients right up front. If they're following the trend of getting better, and week by week, not day by day, but week by week, you ask them, are you getting better, or are you staying the same, or are you getting worse? At that point in time, 2 to 3 months down the road, and somebody who's not incapacitated by their pain, because incapacitated by the pain, you may do their surgery or consider surgery earlier.
Oh, absolutely, sure.
They're bedridden, they can't function, they can't get out of bed.
Of course.
The ones who are not incapacitated, if their answer is I'm getting worse as time goes on, the writing is on the wall. They're not going to get any better anytime soon.
Right.
And there's good information that says that if you allow these patients to have pain beyond a year, that the likelihood of them having chronic pain thereafter is far greater. So recommendations typically are operate on them somewhere between 2 to 3 months and 1 year. And if you do the math in your head, well, obviously it makes much more sense to get them treated sooner if you anticipate they're still going to have their pain beyond a year. So prediction on how they're doing week by week is a very important factor. At 3 months down the road, if they're no better on a week-by-week basis, that's probably somebody who should seriously consider surgery. If they're getting better week by week, then let them get better slowly.
However slowly it may be.
Correct.
Okay.
And then if they do plateau, then you can readdress it at that time.
Right. Dr. Helper, are men or women more or less susceptible to these back issues, or are they pretty much equally distributed amongst boomers of either gender?
Gosh, I gotta say, I'm not sure I know the exact answer to that question. You know, it's my perception that it's pretty equivalent.
I had a feeling it might be, but I thought I'd ask anyway because, well, we have an equal number of men and women listening to the program, and sometimes some of these issues, particularly boomer issues, affect one gender more than the other. So I thought it was a reasonable question.
Right. We are seeing a trend in some of these mechanical conditions as people age that can have a gender trend. So I'm seeing, Dr. Heron mentioned facet arthropathy. That's doctor speak for arthritis of those little joints on either side of the disc. So the little joints in the back corners of our back outside the disc.
That's what you're talking. Okay, and
yeah,
this
so
is where they start to stiffen right up.
Yeah, they get arthritic and they can be painful. Well, that becomes more common to actually be painful as we get older, and it also tends to be more common in men. And with the sacroiliac joint, which is where our tailbone meets our big hip crest bone in the top of our buttock, that arthritic pain we're seeing is becoming more common in women as they age.
Interesting.
Okay, it's not a dramatic trend, but it's a trend that the literature is now showing. So if you ask things do trend with age, I don't know that neurological type pain it trends more in one than the other, but in those two mechanical conditions, which are right next door, there is a trend that we are seeing.
Dr. Heron, do you have any thoughts on this at all?
No, I'm in agreement with everything.
Okay. What is the usual, when one is experiencing this sort of pain and one comes to Falls Creek Healthcare Center, is diagnosed as, well, you're experiencing this pain because now we know you have this condition. What's the usual treatment if you're allowing that patient that 2 to 3 month time span, Dr. Heron, to recover naturally, give them the maximum advantage of Mother Nature assisting in? Do you supplement during that period of observation? Are there meds involved to manage pain at all?
That's actually the mainstay of management should be the mainstay for at least the acute stages in the majority of patients. Medications, analgesics, anti-inflammatories, even narcotic analgesics, and another classification of medications we call neuromodulating medications, which really act on the nerve firing themselves, are the ones that we typically would use for managing these patients. Most patients, though, in the acute stages, when you have an acute episode of back pain in the first few weeks, don't benefit from using physiotherapy or other treatments. They should basically just take the analgesics and stay away from things that worsen their pain, do things that allow them to function, and let things settle down. A perfect example for that would be somebody who has leg pain. So they have radiation of pain down their leg from a nerve that's being irritated by a disc that's herniated or protruded or bulged.
Okay.
In that setting, the only physical modality that may help them is traction therapy in the early stages. Aside from that, visiting a physiotherapist to do IMS and an acupuncturist, they may allow a person to at least have some temporary relief of their symptoms, but it does nothing to change what's going on underneath, which is the disc herniation.
Right.
So although there are modalities that can substitute for medications, in patients who are particularly medication adverse, it's not a bad way to go. But for the majority of the population, it's actually a very expensive route to go and also inconvenient, because if you can't drive yourself to one of these appointments, somebody has to take you.
Exactly.
Which means they have to take time off work, or you have to take a taxi or do something else.
Right.
So in the early stages, time is the biggest benefit for most of these patients.
Right.
And unfortunately, I don't think it's the option that most practitioners out there are using for them. Patients want something actively done.
Right.
And if they think they're pursuing something that's making them better in the early phases, they actually believe at the end that is what made them better. But it's usually time that made them better.
Right. Now, you were talking about this, and I'll put this one to you, Dr. Helper, this period of that's typically 2 to 3 months, a period of observation of the condition of the pain, of the back pain, whatever it might be. And now, so we've learned from Dr. Heron that there are medications also available during this period of observation. During that 2 to 3 month period, how frequently would you like to see that patient to keep check on the condition?
Well, it really depends on the condition that they're coming in for. So if we just keep it narrow for a second,
okay,
and just say, okay, so someone has the symptoms of an acutely pinched nerve, okay, because different conditions have different histories of how they get better, how long it takes, and what your expectations are.
Right.
Let's talk about an acute neurological injury, and let's assume that it's that jelly material from the hockey puck pinching out, right? So how often I would see someone, because I would come second after the family doc. But let's assume the family doc quickly got them to me.
Right.
And now I'm following them. How often I see them depends upon two things. One is how effective my pain control methods are.
Mm-hmm.
Right. So if my suggestions are working, then I can see them only when they need to see me.
Sure.
Right. And the other thing is just watching any kind of borderline neurological signs. So when we talk about the urgency of Dr. Heron stepping in, or the urgency of me stepping in.
Mm-hmm.
Let's more so Dr. Heron relieving the nerve, taking pressure off the nerve. We're talking about things like numbness. So when you don't have proper sensation in that leg, weakness when the motor power, the strength in that leg is going down. So if I see a patient and I'm managing A, pain, and B, watching neurological dysfunction,
right,
weakness or numbness, I'm going to want to see them often if they have medium weakness, numbness. Bad enough that I'm concerned. Maybe we should do something. Maybe
right.
I should get them to Dr. Heron, but not so bad that I'm panicking, and still too early to panic. And knowing that, just as Dr. Heron said, these things get better even with a little bit of numbness and weakness.
Sure.
These get better. So I would see that person every 1 to 2 weeks at the beginning. But if it's just pain and I have good pain control, then just enough to guide them.
But isn't it handy having Dr. Heron just right down the hall?
Oh, he's like my big brother.
No, but I mean, the convenience of it all is amazing. You also mentioned family docs. What percentage of people that you see, Dr. Helper, are there in your office at Falls Creek Healthcare Center because the family doc has said, go see Dr. Helper?
I'd say at this point about 50%.
Interesting.
Yeah.
Okay.
It didn't start that way, but I'd say it's about 50% now, as family doctors become more aware of access for their patients.
Right. Is that the same case with you, Dr. Heron? Are you finding more and more fellow physician referrals?
50% of mine come directly from Dr. Helper.
Okay.
And I send his other 50% come directly from me. So, no, I'd say it's a tough one to really understand. And at Falls Creek, for example, there'll be a lot of patients that are referred through their insurance companies.
Okay.
Their insurance companies see them disabled and unable to work and not being productive, and they want them fixed. Word of mouth is a very important factor.
Mm-hmm.
I heard that somebody had this done, and they were back on the road and functioning again within a few weeks. So that's another thing. Patients who don't want to wait in the public system on a routine basis, some of their family doctors will say, look, if you don't want to wait, go and seek this route.
Sure.
But I think most of it is word of mouth and the appreciation for what Falls Creek's done over the years. And I think that applies to other private facilities, just like it does to physiotherapists' offices and chiropractors' offices.
Yeah. I would say the magical word we haven't mentioned is Google.
Uh-huh.
Right? So
there you go.
The internet, I would say, as I first started working at Falls Creek, the way that would happen was people would be labeled with a condition, like sciatica or disc or joint or whatever medical jargon they were thrown at them. They type it into the computer, they type Vancouver, and through mix and match, the name of of the private surgical center would come up, or the name of a doctor that worked there.
Right.
And that's how then they reach out. But as you know, as time goes on, more family doctors, I think, are more aware of the benefits of early access for certain medical conditions. And spine happens to be one of those conditions where early access is favorable.
It's interesting you would mention the internet. We Canadians are notorious, absolutely notorious consumers of the internet, one of the highest consumers as a country of the internet in the world. And we'll talk a little bit more about that with our guests from Falls Creek Healthcare Center. Dr. Navraj Heron and Dr. Stephen Helper are with us on Boomer Life on CIL 650, and we're back with lots more right after this.
Canada's only weekly radio show dedicated to the baby boomer lifestyle. This is Boomer Life on CIL 650.